Hello, this is Sarah Shakar and I present a video of a DALK. A 57-year-old female was referred to us for long-standing decreased vision in her right eye. She had a known history of keratoconus, which was stable. Her vision in the right eye was not correctable with glasses, and she was not able to tolerate contact lenses. She also had a PK in her left eye by another surgeon and was very happy with the result. Her vision in the right eye was 20/400, pinholing to 20/50. She had a Fleischer ring, void striae, and early lenticular changes, but otherwise her examination was within normal limits. As her vision does not correct with contact lenses, surgery is a viable option here. We counseled her on her options, with DALK being our preferred method, with a chance of conversion to PK. The patient's pupil is constricted preoperatively using pilocarpine. First, we start with anesthesia. A subtenon's injection is used here with 50/50 preservative-free xylocaine without epinephrine and bupivacaine. Next, we measure the limbal white to white to determine the size of the trephination as well as the graft size. Next, mark the cornea with an inked 8-pronged PK marker. This is the vacuum corneal Truffin that we use. First, have the barrel turned all the way out so you can make an imprint on the cornea to determine the centration and whether all pathology is included. Next, pull down the barrel 3/4 turns, which you will account for during retrephination. This allows you to achieve suction once you place the Truffin over the cornea. After you've achieved suction, you do your 3/4 turns and then start cutting. Each quarter turn will cut 62.5 microns of cornea. For an average 400 micron thickness cornea, you can use 6 cutting quarter turns. Next, you check your trephination all around to make sure you have a good depth of trephination. Then you create a tunnel deep in the stroma using a Fogla pointed dissector. Next, you insert a 27-gauge DALK cannula on a 5 cc syringe filled with air to attempt your big bubble. In our first attempt here, we were not very successful, so a second attempt was made, which might have gone all the way through, and a third that seems to have connected everything together. Next, we moved on to our lamellar dissection using a crescent blade to depulk the stroma. Next, we injected air into the AC, which confirmed our big bubble with a donut-shaped configuration of the bubble in the AC. Next, you prepare for your brave slash, which we were successful with here. Then you inject Provisc between the stroma and the decimi. Watch how the bubble in the AC is being pushed to the side, confirming our successful separation. Using a tan marginal dissector, we test all quadrants to the edge of the trephination, after which we cut the remaining stroma into 4 leaflets, which we cut out very carefully using DALK scissors, making sure not to penetrate through the thin decimi. Now we move on to preparing our graft. First, we stain the endothelium with Vision Blue, dry it off, and use a dry Waxel to peel off the decimi and endothelium. We use a full thickness cut to punch out our desired size. We rotate the rim to make sure we're through and through, and we have our graft ready. Now back to our patient, we rinse off the viscoelastic very well, transfer the graft over using a patent spatula, and suture it using Tenno nylon interrupted suture. In this case, we chose to inject an air bubble into the patient's anterior chamber. In this video, we showed a step-by-step DALK, which is an excellent option for patients with keratoconus who have no endothelial pathology. This reduces their chance of rejection, as well as dependency on steroids with the risks of cataract and glaucoma. Make sure to counsel patients on the possible risk of conversion to PK intraoperatively. We showed also if you're unable to attain a big bubble on your first injection, keep on trying. You might get it on the second or third. Also, using an anterior chamber bubble can help confirm your DM separation from stroma as the AC bubble is pushed to the side, forming a donut configuration. Lastly, make sure you take care cutting the stromal leaflets as not to perforate the very thin decimi.